Hi, welcome back to Dr. Isaac's Dentistry. Over the last couple of months, we've kind of introduced you to the office, what to expect when you come in on your first visit, and meeting our staff. Today, what we want to do is kind of do what will happen when you come into the office and we determine that, you know what, we may need to get an oral surgeon involved. So we're going to talk to Doc today about what are those reasons that when we do an evaluation here in the office that would determine us to go ahead and refer you out to an oral surgeon, and what are some of the circumstances that would incorporate that. So Doc, why don't you just start off generally and explain what are those few circumstances that we may refer them?
You know, it's kind of funny. The last show we were bragging about how we're in a small town and we don't have to we don't refer much because we just can't. We got to learn to do it here. But what we do, we refer to an oral surgeon probably daily, if not certainly several times a week, that we will refer a case out. And our biggest referrals, except for orthodontia, except for braces, would be oral surgery. And what's an oral surgery do? He does about anything that needs to be surgically removed, really from the head up, from the neck and mouth and the oral pharyngeal cavity. Now, what do we use them for? We generally use them for tough extractions. If we have an extraction that we know we shouldn't attempt here, or if it's on a close proximity to the nerve, to the inferior alveolar nerve, which runs right underneath the jawbone, we watch every X-ray we look at. We rule that out to whether or not we need to refer it. Also, third molars, wisdom teeth, we refer a lot of those wisdom teeth out too. That can't be done routine simply by a simple extraction here in the office. Another big patient pool would be anxiety. If somebody is just nervous and they can't even stand the thought of getting into our chair, we try to work with them a little bit, but there are certain patients that just can't. They just won't do it. So we see quite a bit of that too.
And on the anxiety portion of that, I'm going to give you a little teaser and a little insight in a little bit about what is possibly coming to our office, but we'll get into that.
Sure.
And then I guess the third and probably least common, but we did have a consult today about it, would be implants.
Sure, yeah. Implants they're been doing this 30 years, and when I first got out of school in '88, it was pretty rare that anybody would even want an implant, but we've been talking about them for a long time. Rule of thumb 30 years ago is if you needed 2 implants, you put in 4 because you knew you were going to have 2 of them. Half of them were going to fail. That's a thing of the past. It's rare now that we see any failures at all with implants. You can put the implants in. The bone will, it's called osseous integrate. The bone will actually grow into the implant and will be actually stronger than what your old root was before.
Right, so I guess, our basic and common reasons for those referrals to an oral surgeon would be tough extractions when that nerve's involved, and Doc's going to show you a great example of that here in a minute. Third molars, wisdom teeth that are way back that would be a little too difficult to handle in our normal setting here, and then implants. Those are probably our top 3 referrals for an oral surgeon, right?
Sure, and back up to the implants, each month that goes by, there's new courses on it, and I get amazed at this. We started a case this morning that's going to be a nice case. We're going to do, it's called the all-on-4 technique, where the surgeon will put in 4 implants. We're going to make him essentially a denture that will be retained. It'll be fixed. It'll be retained in there. He can't get it out. It'll be just like his real teeth. So we're real excited about that.
Yeah. So let's go to the most common we see probably, which is nerve involvement.
Sure.
With that
the inferior
alveolar nerve and those posterior molars and how they'll sit on it. And I'm just going to let you show on this X-ray exactly what we'd be looking at.
Yeah, this is very, very typical in our practice. This was just back in November. We just kind of pulled it up. I saw the fellow not too long ago. But we talk about the inferior alveolar nerve. There's a nerve that runs right into the jawbone, and you can see where this tooth is laying over sideways. And this is the one that was bothering him. So what are we going to do? Well, it really needs to come out, but because of the angle of the nerve, we can't get it out without possibly doing damage to it. Well, so what do we do here in this case? Well, we went up to the top teeth. We took out this tooth right here. This is number 17. So we took out number 16 and relieved the pressure on it. So that's how, sometimes you can juggle it around. This fellow was not, we could not get him into the oral surgeon at the time, and I spoke last time about how difficult it is sometimes to do it, so we have to make do with what we have. The term we used last time was cowboy dentistry. How are we going to get this fellow out of pain and get him functioning again? Well, we'll put him on antibiotics, and we take out this tooth, number 16, relieve the pressure. As you can see, I hope you can see this okay. This is tooth number,
Thank you.
Can you
I'll
see?
point at it.
This is tooth number 32 on the same patient. This one is buried in the jawbone, asymptomatic, has no problems at all. The reason why it has no problems, it's buried down there, bacteria can't get to it. As in this particular tooth, the bacteria can't get in there and cause a problem. We also, before, we don't have an x-ray of this, but we took this tooth out too to relieve the pressure on that, because I knew I couldn't run the risk of damaging that nerve on that, so that's why we did that.
And this is a prime example of that nerve involvement. When you've got this nerve coming down and the roots of this tooth are sitting right on it, can it just be pulled in a regular dental atmosphere? Yes, but you have a high risk of that nerve getting involved and causing some harm.
Sure.
So Doc will refer you over to one of our oral surgeons. We're in a more controlled and a better situation to handle nerve involvement. They can take care of it with some sedation and some other methods to get that tooth out.
And how often does the nerve damage happen with that tooth? All the thousands of teeth I've taken out, I've never had a complication with that, right. But we're careful not to. We're able to choose. Where the surgeons, when we send them over there, they watch that thing too. So it's something we're always cognizant of.
Yeah, and since we've got this x-ray up, one of the things Doc had mentioned about not just her nerve involvement, but third molars or wisdom teeth. This happens to be a wisdom tooth.
Yes.
That is, so it's kind of a double whammy. It's not only a third molar wisdom tooth, but it's also sitting on the nerve.
Yes. Well, wisdom teeth are really the toughest part about a wisdom tooth. Getting it out is getting to it.
Right.
They're just so far back, and that's the complication in it. So that's why they're kind of tough. There can be some of the easier ones to get out because the roots aren't formed very well.
Well, I was going to say, when we can get to them and we've extracted them, they slide right out a lot easier than regular teeth.
A lot of times,
but that complication a lot of times, and the reason we'll get a oral surgeon involved is to get to it.
Oh yeah.
Yeah. Okay. And now, so implants. This X-ray won't really help us on that, but I know one of the big reasons. Well, the oral surgeon, there's sedation involved and things when it comes to the implants, but then there's also other factors that may have to play in, such as bone grafting, adding bone.
Sure.
Can you talk just a little bit about the?
Sure. Whenever you like, if you can see that, if this fellow right here was going to have an implant, Gary, I hope you can see that. Okay. Scott, once you get that, if you can see where the level, that's tissue right there. The level of the bone is up a little bit further. That's the level of the bone. And that next line up is the sinus. So if you went to go put an implant in there, you're going to screw that implant. Actually, I shouldn't use that term. We don't screw them in there. They're placed in there. There are certain times that are self-tapping, but this particular one won't be. But when you place an implant into the maxillary, the upper jaw there, you're going to be in the sinus. Right. So the surgeon would have to do what's called augment the sinus, which would be a sinus lift, where they actually take a piece of the bone in the sinus and just push it up and then fill it with artificial bone. That's pretty common too in a maxillary. You can kind of see here the large sinus over here, not as large on this side, but you see he has all his teeth on this side, so they kind of work in tandem. The teeth kind of hold the bone in there.
Now here at Isaac's Dentistry, like we talked about last time, we do a lot of things. There's not many things we can't do in office. Today we're talking about those things we would refer out to an oral surgeon. And we've got a great relationship with
certainly. Being in Springfield, we refer to Bardstown. We refer to Danville. And Louisville and Lexington too, if you're familiar. So Campbellsville, so being right here in the center of a lot of dentists will work with one surgeon primarily. We see them all the time.
Yeah. So depending on where you live and what's easiest for you, we've got multiple options to get you to an oral surgeon that is not an hour away from where you live. So that convenience also helps with the different relationships that Dr. Isaacs has built up over the years. So,
and depending on what kind of insurance you have, some companies won't take certain things. So it's kind of a, you know, it's a game. But the girls in front, Carrie and Barbara, are very good about working with it and figure out who to call.
Yeah, they can figure it out, and they'll be able to shoot you in the right direction every time. So before we wrap up, so oral surgery is probably our second most common referral outside of orthodontics or braces. We wanted to kind of introduce you to the reasons that here in the office we would say, okay, we're not going to deal with this, but we're going to go ahead and get you to oral surgeon. And you were just talking about doing sinus lifts and things, and I guess that would be another complicating factor that we occasionally see, not often, but an extraction where there's a lot of bone loss, where that upper molar is up into the sinus.
Sure.
I know occasionally we may need to refer them out because of the sinus complications on extracting.
From time to time, you'll see we'll have an oral antral opening, which is we'll actually get communication with the sinus, and that's where we have them to do a few things we'll have them demonstrate in the chair to make sure that it's not perforated.
Right.
And if it is, then we can generally handle it in the office.
Right.
But there are sometimes we do refer for that too.
Yeah.
Another specialist that we use quite a bit would be the pediatric dentist, you know, for young children. A child that we cannot sedate with using nitrous oxide. We use quite a bit of laughing gas on children. We see them early in the morning, right when they're at their freshest. They skipped breakfast. We don't want anything on their tummy, and then we go ahead and sedate them a little bit with the nitrous oxide. Works very well.
And since you brought up this light sedation with the nitrous oxide, we're kind of excited here. We've gone over a lot of things we do here in the dental office. Several months back, we covered our new digital dentistry with our scanner for making crowns and bridges and partial dentures for folks. So one of the things on the other side, as we're talking about sedation, is we're exploring and very close to possibly implementing conscious IV sedation. Correct?
Sure. Been thinking about this for years too. This is something if you've got somebody that just can't have anything done. There used to be, years ago, there was a dentist in North Carolina that we had to refer somebody to because dentists just didn't put patients to sleep. The only specialists that put them to sleep were oral surgeons, and they don't do general dentistry.
Right.
So it was really tough. And the pediatric dentists generally don't see patients older than 18. Some of them cut it off at teenagers, at the teenage years. So it's hard to get that dental phobic treated. So what do? Well, they just don't go, or they let things get so bad that they have to, and it's a nightmare for the patient, and it's a nightmare for the dentist too. I always laugh. There used to be no joke. How much do you charge for nitrous? I said the nitrous is not for you; it's for me. I need to get you sedated in order to do it. But we have changed things around since then. But what Scott was alluding to, that there's just not many dentists that do that. And I've talked to a few anesthesiologists. We've got a CRNA that's going to come in and talk about it. So we're going to try to get that going within the next few months, I believe.
Right. So basically, as Doc was talking about earlier, those patients who just can't stand to sit in our chair, even for filling or a basic extraction, hopefully we're going to be set up here in the next several months to actually be able to bring you in, start an IV, and get you sedated so you can stay calm and keep yourself collected, and we can get into the room and do the work we need to without causing any extra stress for us or for the patient. So we're real excited about that. That's going to be something that I can't think of. Maybe you can, within 75 miles of a general dentist.
There is a general dentist in Louisville that does it. And there used to be a fellow that was a roving dentist that sedated patients whenever you need it, kind of an ad hoc. But I really don't know of anybody that does it, and I've been wanting to do it for a while. I've talked to oral surgeons about it. Dr. Joseph was going to do it at one time, the oral surgeon, and then now he's an MD in Stanford, I believe, so he can't do it.
And what's going to be great about that is we're going to have Dr. Isaacs on site to do the dental work. We're going to have a CRNA here who's got multiple years in sedation who will be in the room to do the sedation. We'll have an aide or a dental assistant that's certified also in the IV sedation. So we'll be fully equipped here in the office to offer something that you really can't get in Springfield, Marion County, Danville, Bardstown area.
Yep.
So I think it'll be a very big convenience. So guys, keep an eye out for that. We'll be making big announcements once we can get things lined up for that. Before we wrap up, Doc, anything else you want to touch on before we let the folks go?
Thank you. You touched many subjects today, many topics. Thanks.
All right. Well, hopefully we've enlightened you a little bit on what we can do here in the office, but more importantly, why we would send you to an oral surgeon instead of you wondering, well, why can't Dr. Isaacs just do that? Hopefully we've given you a better explanation in a calm setting to understand why we do those referrals when we do them. So thanks for joining us, and we'll see you next month here at Dr. Isaacs Dentistry.
Thank you, Scott.